Block, simulation 22. Same process, fresh set, read the command first, scan the clues, build fast, lock and move. 20 questions, 30 minutes. Clock starts now. Which pairing of ECG component and electrical event is correct? A physiologist reviews a normal ECG. He labels the waves and intervals corresponding to the electrical events of the cardiac cycle. Read the command, which ECG pairing is correct. P atrial depolarization, QRS deventricular depolarization, T ventricular repolarization, PR, AV delay. The ECG maps directly onto the heart's electrical events. The P wave represents atrial depolarization, which triggers atrial contraction. The QRS complex represents ventricular depolarization, triggering ventricular contriggering. Atrial repolarization occurs at the same time, but is hidden within the larger QRS. The T wave represents ventricular repolarization, which triggers atrial. The PA interval, from the start of the P wave to the start of the QRS, reflects the time for the impulse to travel through the atria and the AV node, including the AV nodal conduction delay. The correct answer is B. These map to clinical findings. A prolonged PR interval indicates AV block, slowed AV conduction. A widened QRS indicates a ventricular conduction problem, bundle branch block, or ventricular origin, and the QT interval, start of QRS to end of T, reflects total ventricular depolarization plus repolarization prolonged by certain drugs and electrolyte. Abnormalities risking torsates. The P atrial, QRS, ventricular, T repolarization, and PR AV delay pairings are the correct ECG mapping. What is the diagnosis? In the anatomic lesion, a 16-year-old boy is found to have hypertension in the upper extremities, but weak femoral pulses and lower blood pressure in the legs. He has headaches and leg claudication. Chest x-ray shows rib notching. He has a webbed neck and a short Turner syndrome. Read the command, diagnosis, and lesion. Upper extremity hypertension, weak femoral pulses, rib notching, Turner syndrome, coarctation of the aorta. This is coarctation of the aorta, a congenital narrowing of the aorta, classically located near the insertion of the ductus arteriosus, just distal to the left subclavian artery. The narrowing obstructs blood flow to the lower body, so the pressure proximal to the coarctation, the upper extremities, is hic H, upper extremity hypertension and headaches. While the pressure and pulses distal to it, the lower extremities femoral pulses are loud and delayed, causing leg claudication and the classic radiofemoral delay. The correct answer is C. The RIB notching on chest x-ray is a classic clue. Collateral circulation develops through the intercostal arteries to bypass the narrowing, and these enlarged pulsatile collaterals erode the undersides of the ribs. Coarctation is strongly associated with Turner syndrome, as here, and bicuspid aortic valve. The differential blood pressure between arms and legs is the key exam finding. The aortic narrowing causing upper extremity hypertension with weak femoral pulses and rib notching is coarctation of the aorta. Which enzyme is the rate-limiting step of glycolysis, and how is it regulated? A biochemistry student studies the regulation of glycolysis. One enzyme catalyzes the committed rate-limiting step and is the key control point. Read the command, rate-limiting enzyme of glycolysis and regulation. PFK1, activated by AMP and at 26BP, inhibited by ATP and citrate. The rate-limiting committed step of glycolysis is catalyzed by PHO's bofructokinase 1 PFK1, which converts fructose a 6-phosphate to fructose 1,6-bisphosphate. As the key control point, it is tightly regulated by the cell's energy state. PFK1 is activated by signals of low energy and high demand, AMP, signaling low ATP, and fructose 2006, bisphos, the most potent activator, which links to insulin signaling. It is I-inhibited by signals of Hig energy, ATP I-abundant energy, and citrate out signaling that the TCA cycle is well supplied. The correct answer is A. The logic is energy balance feedback. When the cell needs energy, high AMP, low ATP, PFK1 is turned ON to run glucolysis. When energy is plentiful, high ATP, high citrate, it is turned OF. Fructose 2006 bisphosphate is the link to hormonal control. Insulin raises it, promoting glycolysis. Glucagon lowers it, favoring gluconeogenesis. The PFK1 rate-limiting step, activated by AMP and fructose 2006 bisphosphate and inhibited by ATP and citrate, is the answer. Which pairing of valve and auscultation location is correct? A medical student learns where to auscultate the 4 cardiac valves for their characteristic murmurs. Read the command, which valve location pairing is correct. Aortic AR to an ICS, pulmonic AL to an ICS, tricuspid ALLSB, mitral apex. The 4 valve auscultation areas are arranged on the chest wall, and the mnemonic is APTM. All patients take meds, going from top right around to the apex. The aortic valve is heard best at the right T2 intercostal space, upper right sternal border. The pulmonic valve is at the left 2 intercostal space, upper left sternal border. The tricuspid valve is at the left lower sternal border. The mitral valve is at the apex, the 5th intercostal space, midclavicular line. The correct answer is B. These locations reflect where each valve's sound radiates with blood flow, not the anatomic position of the valve. Knowing them lets you localize murmurs. An aortic stenosis murmur is loudest at the right upper sternal border and radiates to the carotids. A mitral regurgitation murmur is loudest at the apex and radiates to the axilla. Maneuvers and positioning help accentuate specific murmurs. The aortic right 2, pulmonic left 2N, tricuspid left lower, sternal, and mitral apex pairings are the correct auscultation map. What is the diagnosis and the embryologic mechanism? A newborn fails to pass meconium in the first 48 hours of life and develops abdominal distension and bilious vomiting. He has Down syndrome. A rectal suction biopsy shows absence of ganglion cells in the submucosal Meissner and myenteric Auerbach plexuses of the distal colon. Read the command, diagnosis, and embryologic mechanism. Failure to pass meconium, Down syndrome, absent ganglion cells in distal colon, Hirschsprung disease, failed neural crest migration. This is Hirschsprung disease, congenital aganglionic megacolon. The embryologic mechanism is a failure of neural crest cell migration. The ganglion cells, which form the enteric nervous system, normally migrate craniocaudally down the gut, but in Hirschsprung, they fail to reach the distal segment. The result is absence of ganglion cells in both the submucosal Meissner and myenteric Auerbach plexuses of the distal colon and rectum. Without the inhibitory enteric neurons, the affected segment cannot relax. It stays tonically contracted, causing a functional obstruction. The correct answer is E. The classic presentation is a newborn who fails to pass meconium in the first 48 hours. With abdominal distension and bilious vomiting, it is associated with Down syndrome. Paradoxically, the aganglionic distal segment is narrow, cannot relax, while the proximal normal colon dilates megacolon. The transition zone is key. Rectal suction biopsy showing absent ganglion cells confirms it. The failed neural crest migration causing aganglionosis and functional obstruction is Hirschsprung disease. Which pairing of nutrient, key enzyme, and absorbable unit is correct? A physiologist studies the digestion of macronutrients. Each is broken down by specific enzymes into absorbable units. Read the command, which digestion pairing is correct? Starchomylase H monosaccharides, protein pepsin trypsin amino acids, peptides, fat thetapides H monoglycerides, FFAs. Each macronutrient has its digestive enzymes and absorbable end products. Carbohydrates, starch, are broken down by amylase salivary and pancreatic into disaccharides. then by brush border enzymes into monosaccharides like glucose, which are absorbed glucose via SGLT1. P proteins are digested by pepsin in the stomach and pancreatic proteases like T-ribopepsin, chymotrypsin, and carboxyl peptidases in the small intestine into amino acids and small peptides. Fats are emulsified by bile salts and digested by pancreatic lipase into monoglycerides and free fatty acids, which are packaged into micelles for absorption. The correct answer is E. The key enzyme substrate matches: amylase for carbohydrates, the proteases, pepsin, trypsin, chymotrypsin for protein, and lipase for fat. Fat digestion uniquely requires bile salts to emulsify the fat into micelles so lipase can act and the products can be absorbed, which is why bile salt or pancreatic deficiency causes fat malabsorption and steatorrhea. The amylase carbohydrate, protease, protein, and lipase D-fat pairings with the correct absorbable units are the answer. What is the drug, its mechanism, and its key feature? A patient presents with a regular narrow complex tachycardia at 180 Amin, paroxysmal supraventricular tachycardia. Vagal maneuvers fail. A drug is given as a rapid IV push that causes a transient AV nodal block and briefly pauses, the heart terminating the arrhythmia, then is gone within seconds. Read the command, drug, mechanism, key feature. SVT, rapid IV push, transient AV block, gone in seconds. Adenosine. The drug is adenosine. The first-line drug for terminating paroxysmal supraventricular tachycardia, PSVT, when vagal maneuvers fail. Its mechanism is to transiently block the AV node. Adenosine activates potassium channels and inhibits calcium influx in nodal tissue, hyperpolarizing the cells and markedly slowing or briefly blocking conduction through the AV node. Since most PSVT involves a reentry circuit through the AV node, this transient block interrupts the circuit and terminates the arrhythmia, restoring sinus rhythm. The correct answer is D. The signature feature is its extremely short half-life, only a few seconds, because it is rapidly taken up and metabolized, which is why it is given as a rapid IV push followed by a saline flush. Patients often experience a brief, alarming sense of impending doom, chest discomfort, or flushing as the heart pauses, but these resolve within seconds. It is contraindicated with significant bronchospasm. The transient AV nodal block terminating SVT with an ultra-short half-life identifies adenosine. What is the diagnosis and the enzyme defect? A 28-year-old woman presents with recurrent attacks of severe, poorly localized abdominal pain, along with neurologic and psychiatric symptoms, anxiety, confusion, neuropathy. Attacks are precipitated by certain drugs, fasting, and alcohol. Her urine turns dark red-purple on standing. Labs show elevated urinary porphobilinogen and ALA. There is no photosensitivity. Read the command, diagnosis, and enzyme. Recurrent abdominal pain, neuropsych symptoms, dark urine, elevated porphobilinogen, ALA, no photosensitivity, acute intermittent porphyria, porphobilinogen deaminase deficiency. This is acute intermittent porphyria, a disorder of hemisynthesis caused by a deficiency of porphobilinogen, deaminase also called hydroxymethylbelane synthase. The block causes accumulation of the upstream precursors aminolevulinic ACILA and porphobilinogen, which are neurotoxic. This produces the classic neurovisceral attacks, severe, poorly localized abdominal pain, often mistaken for a surgical abdomen, plus neurologic and psychiatric symptoms, peripheral neuropathy, anxiety, confusion, and autonomic instability. The urine characteristically darkens to a red-purple color on standing. The correct answer is A. The key discriminator is the absence of photosensitivity, with prominent neurovisceral symptoms and elevated ALA and porphobilinogen, distinguishing it from porphyria synthase desynthase. Tarda, which causes photosensitivity and blistering skin deficiency of urocorphorinogene decarboxylase. Attacks are precipitated by cytochrome P450 inducers, certain drugs, fasting, and alcohol, which upregulate ALA synthase, certain drugs, fasting, and alcohol, which upregulate ALA synthase. Treatment is glucose, a hemin, to downregulate ALA synthase. the porphobilinogen deaminase deficiency with neurovisceral attacks and no photosensitivity is acute intermittent porphyria. Which organism is responsible? A traveler returns from South Asia with about a week of rising stepwise fever, relative bradycardia, abdominal pain, constipation, then diarrhea, and pink macules on the trunk rose spots. Hepatosplenomegaly is present. Blood culture grows a gram-negative rod. Some patients become chronic carriers via the gallbladder. Read the command. Which organism? Travel, stepwise fever, relative bradycardia, rose spots, gallbladder carrier, Salmonella typhi, typhoid fever. This is typhoid enteric fever caused by Salmonella typhi, a gram-negative rod acquired via the fecal-oral routes, common in travelers to South Asia and other endemic regions. The classic presentation is a gradually rising, stepwise fever over the first week, relative bradycardia, a slower pulse than expected for the fever, Faggot sign, abdominal pain with constipation early that may progress to pea soup, diarrhea, hepatosplenomegaly, and the characteristic salmon-colored rose spots on the trunk. The correct answer is C. A key feature is the chronic career state. Salmonella typhi can persist in the gallbladder, especially with gallstones, and these chronic carriers shed the organism and can transmit it the historical typhoid mare. It invades through the gut into the lymphatics and bloodstream, and complications include intestinal perforation. Treat with fluoroquinolones or ceftriaxone, and a vaccine exists. The stepwise fever with relative bradycardia, rose spots, and gallbladder carriage identifies Salmonella typhi typhoid fever. What is the diagnosis, the mechanism, and the treatment? A 65-year-old man with small cell lung cancer is found to have a serum sodium of 120 mkl. He is clinically EU volemic, not edematous, not dehydrated. Labs, low serum osmolality, but INAP appropriately, concentrated urine, high urine osmolality, and elevated urine sodium. Read the command, diagnosis, mechanism, treatment, SCLC, euvolemic hyponatremia, low serum osmolality, concentrated urine, SIADH, fluid restriction. This is SIAH, the syndrome of inappropriate antidiuretic hormone secretion. ADH is secreted in XTSS inappropriately despite low plasma osmolality, here from ectopic production by the small cell lung cancer. The excess ADH causes the kidney to retain free water, diluting the blood and producing a euvolemic hyponatremia. The patient is not edematous or dehydrated, but the serum sodium and osmolality are lower. Because ADH is acting, the urine is ion appropriately, concentrated high urine osmolality, with elevated urine osmolality, with elevated urine sodium, even though the blood is dilute. The correct answer is A. The diagnostic profile is the key. Euvolemic hyponatremia with LOW serum osmolality, but a concentrated urine. The urine should be maximally dilate if ADH were appropriately suppressed. Causes include small cell lung cancer, ectopic ADH, CNS disorders, pulmonary disease, and drugs. Treatment is FLUID restriction first line. Severe symptomatic hyponatremia may need hypertonic saline, corrected slowly to avoid osmotic demyelination, and ADH antagonists, Vaptans, or dimethyl can be used. The excess ADH causing euvolemic hyponatremia with concentrated urine treated by fluid restriction is SIADH. What is the diagnosis, the pathology, and the danger to monitor? A 35-year-old man develops progressive, symmetric, ascending weakness over several days, starting in the legs and moving upward with loss of deep tendon reflexes. He had a diarrheal illness, Campylobacter jejuni, a few weeks ago. CSF shows Hitch protein with a normal cell count, albuminocytologic dissociation. Read the command, diagnosis, pathology, danger. Ascending weakness, arflexia, post-Campylobacter, albuminocytologic dissociation. Guillain, Barré, peripheral demyelination, respiratory failure risk. This is Guillain-Barré syndrome, an acute autoimmune demyelinating polyneuropathy of the peripheral nervous system. It is often post-infectious, classically following Campylobacter jejuni, gastroenteritis, molecular mimicry between bacterial and nerve antigens, or other infections. The hallmark is a progressive, symmetric, ascending weakness, starting in the legs and moving upward, with LOS of deep tendon reflexes, areflexia. The CSF shows the classic AL-Bu-cytologic dissociation Hic protein with a normal cell count. The correct answer is D. The danger to monitor and the high yield management point is respiratory failure. The ascending paralysis can reach the diaphragm and respiratory muscles, so cerebropulmonary function, vital capacity, and respiratory status must be monitored closely, with mechanical ventilation if needed. Autonomic instability is also a risk. Treatment is IVG or plasmapheresis, not steroids. The peripheral demyelination causing ascending paralysis with albuminocytologic dissociation with respiratory failure as the key danger is Guillain-Barré syndrome. What type of hearing loss is in the right ear? A patient with new hearing loss in the right ear undergoes bedside testing. On the Weber test, tuning fork on the forehead, the sound lateralizes to the left, the good ear. On the Rennie test, air conduction is greater than bone conduction in both ears, normal Ren. Read the command. Which type of hearing loss? Weber lateralizes to the good left ear, Rennie normal, bilaterally, sensory neural loss in the right ear. Interpret the two tuning fork tests together. The Weber test, in sensorineural hearing loss, the sound lateralizes to the good unaffected ear, because the affected inner ear nerve perceives sound poorly. Here it lateralizes to the LEF to good ear, pointing to a problem in the right ear that is sensorineural hearing. The Rennie test compares air conduction AC to bone conduction BC. A normal Rennie is AC greater than BC, which is preserved in sensorineural loss. Both AC and BC are reduced proportionally. Both findings indicate a sensorineural hearing loss in the right ear. The correct answer is C. Contrast the patterns. In conductive hearing loss, the Weber lateralizes toward the affected bad ear. The conductive block lets the bad ear hear bone conducted sound better and masks ambient noise, and the Rennie is abnormal on the affected side, BC greater than AC, because the conduction apparatus is blocked, but the nerve works. So, Weber to the bad ear with abnormal Rennie conductive, Weber to the good ear with normal Rennie sensorineural. The Weber lateralizing to the good ear with a normal Rennie indicates a right sensorineural hearing loss. What are these phenomena? During therapy, a patient begins reacting to her male therapist as though he were her critical, demanding father, becoming defensive and seeking his approval. Separately, the therapist notices he feels unusually protective of the patient because she reminds him of his own daughter. Read the command, what these phenomena are. Patient-therapist, father feelings, therapist, transference, therapist, patient, daughter feelings, these countertransference. These are transference and countertransference. Transference is when the patient redirects feelings and attitudes from an important person in their past, often a parent, onto the therapist or physician. Here, the patient reacts to her male therapist as if he were her critical father, projecting that paternal relationship onto him. Countertransference is the reverse, when the therapist-physician redirects their own feelings onto the patient. Here, the therapist feels protective because the patient reminds him of his daughter. His personal feelings are projected onto her. The correct answer is D. The direction is the key to telling them apart. Transference flows from patient to doctor. Countertransference flows from doctor to patient. Recognizing countertransference is important for physicians because their own unexamined feelings can interfere with objective, appropriate care. Both are normal phenomena to be aware of and manage in the therapeutic relationship. The patient's transference of paternal feelings and the therapist's countertransference of paternal feelings toward the patient are the answer. What is this disorder? A newborn has coarse facial features, restricted joint movement, clouded corneas, and developmental delay. Labs show HIH levels of lysosomal enzymes in the blue serum, but the cell's lysosomes lack these enzymes. The enzymes were not properly targeted to the lysosome. The defect is in adding the mannose 6-phosphate tag. Read the command. Which disorder? Coarse features, clouded corneas, high serum lysosomal enzymes but empty lysosomes, mannose 6-phosphate defect, eye cell disease. This is eye cell disease mucolipidosis 2. The defect is in the enzyme that adds the mannose 6-phosphat M6P tag to lysosomal enzymes in the Golgi. This M6P tag is the address label that directs newly made lysosomal enzymes to the lysosome. Without the tag, the lysosomal enzymes are not delivered to lysosomes. Instead, they are mistakenly secreted outside the cell into the blood. So the lysosomes are deficient in enzymes and fill with undegraded substrate, forming inclusion bodies, hence eye cells, while serum levels of lysosomal enzymes are paradoxically HIGH. The correct answer is A. The paradoxical finding: H lysosomal enzymes in the blood, but deficient enzymes inside the cell's lysosomes, is the diagnostic signature, and it points to a trafficking targeting defect rather than a missing single enzyme. Clinically, eye cell disease resembles severe Hurler syndrome with coarse facial features, clouded corneas, restricted joint movement, gingival hyperplasia, and developmental delay, and is usually fatal in childhood. The failed mannose 6-phosphate tagging causing mislocalized lysosomal enzymes is eye cell disease. What is the diagnosis and the mechanism of the steatorrhea and diabetes? A 50-year-old man with a long history of heavy alcohol use presents with chronic dull epigastric pain, weight loss, greasy foul-smelling stools, steatorrhea, and new diabetes. CT shows pancreatic calcifications and ductal dilation. Read the command, diagnosis and mechanism. Chronic alcohol, epigastric pain, steatorrhea, diabetes, pancreatic calcifications, chronic pancreatitis, exocrine and endocrine failure. This is chronic pancreatitis, irreversible inflammation, fibrosis, and calcification of the pancreas, most commonly from chronic alcohol use, and other causes like cystic fibrosis, hereditary, or ductal obstruction. Over time, the destruction of pancreatic tissue causes loss of both of the gland's functions. Loss of exocrine function, the digestive enzymes, causes maldigestion and malabsorption, classically of fat, producing greasy, foul-smelling steat, torhea, and weight loss and fat-soluble vitamin deficiencies. Loss of endocrine function, the islet cells, causes diabetes mellitus. The correct answer is E. The CT signature is pancreatic calcifications with ductal dilation reflecting the chronic fibrocalcific destruction. The combination of chronic epigastric pain, steatorrhea, exocrine failure, and diabetes endocrine failure in a patient with a heavy alcohol history is classic. Complications include pancreatic pseudocysts and an increased risk of pancreatic pseudocysts, and an increased risk of pancreatic pseudocysts, and an increased risk of pancreatic cancer. Treatment includes pancreatic enzyme replacement, pain control, and managing the diabetes. The fibrocalcific destruction causing combined exocrine, steatorrhea, and endocrine diabetes failure is chronic pancreatitis. Which pairing of fiber type and its properties is correct? A physiologist studies skeletal muscle fiber types. A marathon runner's muscles are rich in one fiber type. A sprinter's muscles are rich in another. Read the command. Which fiber type pairing is correct? Type: IS slow, oxidative, fatigue resistant, red endurance. Type 2 fast, glycolytic, fatigable, white sprint. Skeletal muscle has two main fiber types, TYPE. I, slow, twitch fibers rely on oxidative metabolism. They have abundant mitochondria and a rich blood supply and high myoglobin content, which gives them a red appearance. They contract slowly but are fatigue resistant, ideal for sustained endurance activity, like a marathon runner's muscles. TYPE2, fast twitch fibers, rely on anaerobic GLY colysis. They have fewer mitochondria and less myoglobin, a whiter appearance, contract rapidly and powerfully, but fatigue quickly, ideal for short bursts of power, like a sprinter's muscles. The correct answer is C. A memory aid, one slow red ox. Type 1 fibers are slough, red, and oxidative endurance, and 2 fast white. Type 2 fibers are fast, white, and glycolytic power. The red color comes from the high myoglobin and mitochondrial content of type I fibers. So the marathon runner is enriched in type I slow oxidative and the sprinter in type 2 fast glycolytic fibers. The type I slow oxidative red endurance and type 2 fast glycolytic white sprint properties are the correct pairing. What distinguishes the two stages of this condition and what drives the advanced stage? A 58-year-old man with poorly controlled type 2 diabetes for 15 years has a dilated retinal exam. Findings include microaneurysms, dot and blot hemorrhages, hard exudates, and cotton wool spots. In the more advanced stage, fragile new vessels grow on the retina and optic disc neovascularization, risking vitreous hemorrhage and retinal detachment. Read the command. Distinction between stages and driver of advanced stage. Non-proliferative, microaneurysms, hemorrhages versus proliferative, neovascularization, VEGF driven from ischemia. Diabetic retinopathy has two stages. Non-proliferative. Diabetic retinopathy is the earlier stage, characterized by damage to the retinal microvasculature, microaneurysms, dot and blot hemorrhages, hard exudates, lipid deposits, and cotton wool spots, microinfarcts. Proliferative. Diabetic retinopathy is the advanced, vision-threatening stage, defined by novascularization, the growth of fragile neoplasticization, the growth of fragile new blood vessels on the retina and optic disc. These new vessels bleed easily, causing vitreous hemorrhage, and their fibrous scaffolding can contract and cause retinal detachment. The correct answer is D. The driver of the proliferative stage is the key mechanism. Chronic hyperglycemia damages and occludes retinal capillaries, causing retinal ischemia and hypoxia. The hypoxic retina releases VEGF, vascular endothelial growth factor, which stimulates the abnormal neovascularization. This is why treatments target VEGF, anti-VEGF injections, and the ischemic drive laser photocoagulation. The progression from non-proliferative microvascular damage to VEGF-driven proliferative neovascularization distinguishes the two stages. What are the key toxicities of valproate and a critical teratogenic risk? A 24-year-old woman with epilepsy and also bipolar disorder is treated with valproic acid. She is counseled about monitoring liver function and is strongly advised about contraception. Read the command, key toxicities and teratogenic risk. Valproate, hepatotoxicity, pancreatitis, weight gain, and neural tube defect teratogen. Valproic acid, valproate, is a broad-spectrum anti-epileptic and mood stabilizer that works by blocking sodium channels and increasing GABA. Its key toxicities include hepatotoxicity, which is why liver function is monitored, and it can rarely be fatal, pancreatitis, weight gain, tremor, hair loss, and thrombocytopenia. The critical reproductive concern is that valproate is a potent teratogen. It causes neural tube defects like spina bifida by interfering with folate, which is why it is avoided in pregnancy and why women of childbearing age need effective contraception and folate supplementation. The correct answer is B. The two high seal points are the hepatotoxicity monitor LFTs, especially early and in young children, and the neural tube defect teratogenicity, avoid in pregnancy childbearing potential. This contrasts with the other anti-epileptic toxicity signatures. Phenytoin causes gingival hyperplasia and zero-order kinetics. Ethambutol, manti-TB, causes optic neuritis. Carbamazepine causes agranulocytosis, and serial-TB causes optic neuritis. Carbamazepine causes optic neuritis and DADH aldehyd amethyst-style bearing potential. The valproate hepatotoxicity, pancreatitis, and neural tube defect teratogenicity are the answer. What is the virus, the mechanism of this reactivation, and a potential complication? A 70-year-old man develops a painful vesicular rash and a band-like dermatomal distribution on the left side of his trunk that does not cross the midline. He had chickenpox as a child. The rash is preceded by burning pain. Read the command: virus, mechanism, complication, dermatomal vesicular rash, prior chickenpox reactivation, varicella zoster, latent in dorsal root ganglion, posthepatic neuralgia. This is shingles, herpes zoster, caused by reactivation of varicella zoster virus (VZV). After a primary chickenpox varicella infection in childhood, the virus becomes latent in the sensory dorsal root ganglia or cranial nerve ganglia. Later in life, especially with age or immunosuppression, when cell-mediated immunity wanes, the virus re-activates, traveling down the sensory nerve to the skin. This produces a painful vesicular rash in a dermatomal distribution that respects the midline corresponding to the single nerve's territory, classically preceded by burning pain or tingling. The correct answer is E. A key complication to know is postherpetic neuralgia, persistent, often severe neuropathic pain in the affected dermatome lasting months after the rash resolves, more common in the elderly. Other complications include herpes zoster ophthalmicus D1 involvement, threatening the eye, and Ramsay-Hunt syndrome, facial nerve. Antivirals, acyclovir, given early reduced severity, and a zoster vaccine prevents reactivation. The dermatomal vesicular rash from VZV reactivation out of a dorsal root ganglion with postherpetic neuralgia as a complication is shingles. Which pairing of immunoglobulin isotype and its primary function is correct? An immunology student reviews the antibody isotypes and their functions. Read the command. Which isotype function pairing is correct? IgG, placenta, opsonization, AGA, secretory, AGM, first pentamer complement, AGE, allergy parasites. Each immunoglobulin isotype has distinct functions. IgG is the most abundant serum antibody. It is the only one that crosses the placenta, providing passive neonatal immunity, and it mediates opsonization, complement fixation, and neutralization, the main antibody of the secondary immune response. IgA is the secretory antibody found at mucosal surfaces, gut, respiratory tract, and saliva, tears, and breast milk, where it protects against pathogens. It exists as a dimer in secretions. IgM is the first antibody produced in a primary response. It is a pentamer, making it the best activator of complement. IgE mediates allergy and antiparasitic defense by binding mast cells and basophils. The correct answer is B. Quid memory hooks IgG goes across the placenta and is the greatest in amount, IgA, areas of mucosa, and is in secretions. Breast milk, IgM, is the massive pentamer and is the I immediate, first responder and best at complement. IgE is for everything allergic and parasites. IgD is mostly a B-cell receptor. The IgG placenta, opsonization, IgA, secretory, IgM, first pentamer complement, and IgE, allergy parasite pairings are the correct isotype functions. Block 22 is done. Let's review the 5 biggest traps from this block. Trap 1. Coarctation of the aorta causes upper extremity hypertension with weak, delayed femoral pulses and rib notching from collaterals, associated with Turner syndrome and a bicuspid aortic valve. Trap 2. Acute intermittent porphyria causes neurovisceral attacks, abdominal pain, and neuropsychiatric symptoms, with elevated ALA and porphobilinogen, but no photosensitivity. Porphyria cutanea tarda is the one with photosensitivity. Trap 3. Side causes euvolemic hyponatremia with an inappropriately concentrated urine from excess ADH. Treat with fluid restriction and correct sodium slowly to avoid osmotic demyelination. Trap 4. Guillain-Barré causes ascending paralysis with areflexia and CSF albuminolcytologic dissociation. The key danger is respiratory failure, so monitor vital capacity. Treat with IVIG or plasmapheresis, not steroids. Trap 5. In sensory neural loss, the Weber lateralizes to the good ear and Rennet is normal. In conductive loss, the Weber goes to the bad ear and the Rennet is abnormal on that side. 22 blocks. 440 questions. Train process, not memorization. StepLogic. Learn how to think, not memorize.